is your patient experiencing fatigue, or could there be an underlying cause such as narcolepsy? Timely referral to specialists is essential to confirm the diagnosis, to help optimize treatment, and ensure that patients can benefit from current and new emerging therapies.
This podcast is for healthcare professionals only and is supported by an independent educational grant from 𝗃𝗃𝗃𝗃.
Hello and welcome. My name is Dr. Markus Schmidt. I am head of sleep medicine at the Inselspital in Bern University Hospital in Switzerland, and I'm here today with my colleague, Anna.
Hello, Markus. Nice to meet you. My name is Dr. Anna Heidbreder. I'm neurologist and sleep specialist at the University Hospital in Bochum in Germany. And I'm very happy to discuss about narcolepsy type 1 today.
So today we'll be discussing the emergence of novel orexin 2 receptor targeted treatment strategies and why efficient recognition of narcolepsy type 1 and early referral to specialists are becoming increasingly important in this domain. So maybe we can start with a few questions, Anna. My first question maybe for you is, how is narcolepsy type 1 currently managed in clinical practice? And what limitations do you see still with the existing treatments?
Yes, this is a very important question because I think the disease itself differs a lot in patients. So I think at the moment there are actually no patients who are treated exactly in the same way as another. Therapies often consist of various components that address different symptoms, making it highly individualized. And to be honest, in many cases, there are still symptoms that affect daily living of this patient. So in some patients, excessive daytime sleepiness is the most important, and we address this. And in some, it's more cataplexy, but many need treatment for both. And yeah, it's very individualized and not perfect, of course.
Given these limitations, how do you see the emerging therapies and how they aim to maybe change this approach?
With this new treatment options, the orexin 2 receptor agonists, there starts a new era in treatment of narcolepsy, especially in younger people. Drowsiness or sleepiness is often attributed to behavioral factors, so that right questions may simply not be asked in these patients. And the red flags are not recognized in these patients. And with the new era of new treatment, all these symptoms could be addressed with one medication, maybe. But I think we have to step back one step. And I ask you, Markus, maybe you can give an insight into these newer therapies and this important or potential impact in our clinical practice.
I like to say we're in maybe a golden era of narcolepsy research, because about 25 years ago, we discovered what the cause of narcolepsy was and the loss of this orexin or hypocretin neuropeptide. And there are currently a number of clinical trials ongoing with these different molecules that are orexin 2 receptor agonists. And particularly, there are two key phase 3 studies that just have come to completion, the First Light and Radiant Light studies. And these studies had a primary outcome or endpoint of objective wakefulness assessed by what we call the maintenance of wakefulness test. This is the objective ability to stay awake. And there were other key secondary endpoints, including the patient's subjective sleepiness, which is rated using the Epworth sleepiness scale, and the weekly cataplexy rate. And both of these studies met their primary and key secondary endpoints. And specifically, there was a statistically significant improvement versus placebo in the objective wakefulness, so the ability to stay awake, the subjective sleepiness and cataplexy, There were improvements were observed by the week 12 and were consistent across the core symptoms of narcolepsy. And there were additional improvements in other symptoms as well that we talk about in narcolepsy. Particularly, there are some hallucinations that can happen with sleep onset or waking up from sleep, what we call sleep paralysis and quality of life. They all showed improvements in these studies. And from a safety perspective, they were generally well tolerated. No serious treatment-related adverse events that were reported. And the most common adverse events were insomnia and urinary frequency or urgency. But these were typically mild to moderate. Most started within the first day or two, and they were transient. And finally, I would say there are a number of other such medications that are currently in the pipeline that are undergoing development. So it's an exciting time for narcolepsy research, I would say. Maybe a question for you, Anna, is based on these data, what do you see as the potential clinical impact of the orexin 2 receptor agonists in the management of narcolepsy type 1?
Thank you for showing this nice data or telling something about this really nice data. And I completely agree. It's a golden era for narcolepsy patients. So as you clearly illustrated, using the study data, we can hope that in the future we can have another, likely much more specific medication at our disposal, which will significantly expand our treatment options. And it might be possible that this might allow us to manage patients with the monotherapy, maybe to address all the symptoms you just mentioned, and which could have significant implications for the overall course of the disease. As usual, young people are affected very early in their life. They will need medication the whole life. And so early addressing all symptoms with one medication could be a possible future for them, maybe.
Yes, I agree. So given these advances and the ongoing trials, early recognition is becoming obviously increasingly important. And what are the main challenges in recognizing narcolepsy in clinical practice that you see?
It's still a problem to recognize narcolepsy type 1 early enough. So there are data from Europe which still show that from the first symptoms of narcolepsy to diagnose it, it still takes 7 to 10 years. And this is really a long time. If you are aware that usually young adults are affected by narcolepsy, or even in a young childhood, the narcolepsy starts. So knowing the symptoms of narcolepsy is key. So excessive daytime sleepiness is not due to media usage at night or less sleep during night. This could really be a symptom of narcolepsy. And as you mentioned, the additional symptoms have to be asked. So the red flag symptoms, as you said, hallucination or sleep paralysis or automatic behavior. But a physician has to ask these questions. And one of the most important symptoms in narcolepsy type 1 we are talking about today is, of course, cataplexy, which is difficult to ask if you are not experienced as a sleep specialist. But the emotion associated loss of muscle tone, being completely aware during this cataplexy, you should ask for that. And then you can pass the way for the patient to get an investigation in a sleep center, for example. But you have to ask this question. And I think most of the physicians just don't ask these questions. And this is important, of course.
I was also going to mention, you talked about the young people with sleepiness. I find that it gets even perhaps sometimes more challenging when we have patients coming in that are maybe in their 40s and 50s, and many people start to think of sleep apnea, and the patient can go down a road of at least a presumed diagnosis that may miss the opportunity to identify narcolepsy. So I think it depending on the age when they present, it can be sometimes a bit challenging to identify these patients. So thinking about a patient, with a delayed diagnosis, what are the key features that you think are often missed?
I think to ask the correct questions about the symptoms like hallucination and sleep paralysis, and about the whole story, going back, because in most of the patients, the disease started much earlier, but they found a way to manage somehow. And in some patients, cataplexy, for example, must not be completely. In some patients, they have only partial cataplexy. For example, they just feel the muscle loss in the face or in the neck, and they do not completely fall to the ground. So it's really important to ask these key questions and to go back in the anamnesis and listen, ask the right question to the patients. I think this is super important. And of course, getting access to a sleep specialist is often really difficult.
Yes, I agree. And in your experience, what is the impact to the patient of a delayed diagnosis?
And many patients, as I mentioned before, are very young when they start to have narcolepsy. And this is the time they get trained, they start job, etc. And this is a very important time of their life. And so the earlier they get the diagnosis, the earlier they get access to treatment, and the earlier they are part of the community again, and are successful in doing a job and finish school, for example.
Just be able to succeed in life and be as optimally awake and alert is something we all sometimes wish we could do better at.
Yes, if we want to optimize diagnosis and find the right way for referral pathways, what, in your opinion, are the key signs that should be prompt the suspicion of a narcolepsy or to a referral?
Obviously, we both have mentioned a couple of them. I think the excessive sleepiness and cataplexy together is a key one, right? I mean, somebody who's sleepy, having difficulty maintaining alertness, especially this is in sedentary situations, reading, watching television, sometimes even in conversations with friends. And then that together with the cataplexy, this weakness in the knees triggered by emotion, oftentimes can be partial with just a very a slacking of the jaw, a slurring a bit of the speech that's triggered by some sort of emotion. Very, very key to be thinking about narcolepsy. Then we talk about the other associated symptoms, like, as I mentioned, the hallucinations, this drifting off into sleep. It's the dream, if you will, it's coming too early. Even while we're still a little bit awake, or the dream persisting even when we wake up. So we have the hallucination before or after we wake up from sleep. The sleep paralysis, again, this paralysis is part of normal dream sleep. We are paralyzed, but can also be hanging on longer than it should as we wake up from sleep and we feel paralyzed. And then there's this paradoxical thing for narcoleptics is they're so sleepy in the day, yet they have such fragmented sleep at night. And this disrupted nocturnal sleep is also a key element. And so I think it's important to recognize these clusters of symptoms, and rather than just looking at one symptom or isolating on a certain symptom. And, referral to a sleep specialist is important so that they can really get started to do the appropriate diagnostic tools. And this includes an overnight sleep study. Obviously, we want to rule out another potential cause of sleepiness, like sleep apnea. There's a daytime nap testing, the multiple sleep latency test, we call it, to look at the objective sleepiness. And we also look for REM sleep occurring in these naps. That is a nice hallmark of narcolepsy. And then finally, when available, getting cerebrospinal fluid, a lumbar puncture, to actually examine the orexin levels to really make sure that the patient is orexin deficient.
I think very important steps we have to mention in the diagnostic pathway of the patient. So may I ask you to conclude a little bit, Markus, on what we were discussing? What are the take-home message from our discussion?
If I would have made the key points, I would say number one is treatment options are emerging. The orexin 2 receptor agonists represent a major shift toward targeting the underlying cause or biology of narcolepsy type 1 and has the potential to significantly improve patient outcomes. And number two is early recognition, as we talked about. It is critical. Narcolepsy is often underdiagnosed or misdiagnosed. So clinicians should maintain a high index of suspicion, particularly in patients with excessive daytime sleepiness who have these other associated symptoms, but particularly cataplexy, obviously. And finally, act early and refer appropriately. Timely referral to specialists is essential to confirm the diagnosis, to help optimize treatment, and ensure that patients can benefit from current and new emerging therapies.
Yes, I completely agree. So thank you very much for the discussion, Markus.
Anna, it's been a pleasure with you today.
If you enjoyed this podcast and want to find out more, then please look for the Rare Diseases Medical Conversation podcast under the account of 𝗁𝗄𝗏 Medical Education. Also, don't forget to rate this podcast, subscribe to your channel, and share it with your colleagues. Thank you for listening and see you next time. This podcast is an initiative of 𝗁𝗄𝗏. The views expressed are the personal opinions of the experts. They do not necessarily represent the views of the experts' organizations or of 𝗁𝗄𝗏. For expert disclosures on any conflict of interest, please visit the 𝗁𝗄𝗏 website.